Alright, it's 3:18. So I'm going to be doing two nerve blocks today. So before I go into the room, I'm going to look at my patient's chart. I'm going to review my patient's health history for any abnormalities, labs, coagulation, platelets greater than 100,000. I'll then go into the room, introduce myself as the anesthesia provider, going to do two nerve blocks, which are going to be the tap and axillary blocks. Hi, my name's Adam. We're going to be doing two blocks today. The tap block is going to be for your abdominoplasty and liposuction. That's going to help reduce postoperative pain. The risks to that are peritoneal puncture, and it can spread to your femoral nerve and cause leg weakness, causing you to be a fall risk. The alternative would be to not do this block and just give you more pain meds, which can lead to more complications from opioid use, such as increased post-op nausea and vomiting or constipation. For your axillary block, that's going to be for your surgery on your wrist today. Anything below this block is good for anything below your elbow. Risks to this block are local anesthetic systemic toxicity, because this is a highly vascular area, so we want to be careful and visualize all the vessels in that area before injecting. So we went over risk benefits and indications for these blocks. Other comorbidities that you have: you're a 50-year-old female, so you also have diabetes, hypertension, and obesity. With your diabetes, this can lead to increased risk of infection and delayed wound healing. We have to assess any sort of neuropathy before the procedure. With your hypertension, it can lead to increased risk of bleeding, and with your obesity, we might have to use a longer needle, and it may be harder to visualize certain structures. So if this is something you want to proceed with, we're going to get a consent form signed. All right, we fill that out. Now I'm going to gather all my supplies. I'm going to be gathering syringes, 2 syringes with a stopcock attached to my 22 gauge Stimuplex needle. That's going to allow me to use a peripheral nerve stimulator as well. I want 0.25% ropivacaine, and I'll be using sedation, so I have 2 milligrams of midazolam, and I'm going to be giving 30 milligrams of ketamine as well. I'm going to be doing a sterile procedure, so everyone in the room has to wear masks. So, mask for the patient, put that on. We're going to be using sterile drapes, sterile prep, sterile gloves, and ultrasound probe cover, ultrasound, and an assistant, and normal saline to hydrodissect with my tap block. We're going to hook up my patient to all the monitors that are standard. We're going to be doing pulse oximetry for SpO2 and heart rate, EKG to monitor any arrhythmias associated with intravascular injection. We're going to do end-tidal CO2 and possibly oxygen due to sedation, and then blood pressure. So we'll do a timeout with everyone in the room, make sure we have the correct patient, we're doing the correct procedure, the correct block, and on the correct side. So this is going to be a left axillary block because of a left wrist fracture, and then while we're at it, we're going to be doing a left-sided tap block to begin with, and then I'll finish up later on and do the right side to complete the full pain, full analgesia around the abdomen for abdominoplasty. So I'm going to gather my sterile supplies. I'm going to open up my sterile prep, put on my sterile gloves. I'm going to grab my prep to clean my patient. Start by cleaning off the axillary site. I'll let that soak and dry, and then I'm going to apply drape. I have a gown on, cap. Patient has a mask on, so now we can grab our ultrasound probe cover, and with our assistant, we're going to place it over the ultrasound sterilely. Apply some gel to my site. And then with the axillary block, like I said, it's a highly vascular area. So we're looking for the axillary artery right here in the center. That's pulsatile. We know that the veins are easily occluded, so we want to make sure to avoid those structures. And then in a counterclockwise direction, we have the radial muscle, the radial nerve to ulnar nerve medially or laterally, and then superiorly we have the median nerve. And then we're going to look and scan proximally on the patient to look for the musculocutaneous nerve, which is coursing through the coracobrachialis muscle. I'm going to say this is the median, or the musculocutaneous nerve. We have the triceps down here. So my approach, I'm going to be approaching from a cephalad to caudad position with my needle. Once again, the patient is sedated with 1 to 2 milligrams of Versed, 30 milligrams of ketamine. The reason why we want this patient awake for this block is because it can result in blast, and we want the patient to be able to tell us if they have any symptoms such as tingling in their mouth or around their mouth or in their ears. And in case we go intraneural and inject, that can cause some severe pain. So I'll grab my needle. And I'm going to approach cephalad to caudad. And we can use the nerve stimulator, starting off with the musculocutaneous nerve. And that's going to elicit an upper arm twitch. And then we can have our assistant aspirate. With the nerve stimulator, we have a goal of 0.3 to 0.5 milliamps. Then we'll aspirate and then inject our 0.25% ropivacaine. Then we'll withdraw the needle and redirect that towards below the axillary artery, avoiding those vessels, aspirating, and we can use our peripheral nerve stimulator again and elicit at 0.3 to 0.5 as our goal some finger twitches. So we aspirated, injected our 0.25% ropivacaine, and then withdraw our needle and redirect superiorly towards the median nerve. And once again, use the nerve stimulator if you feel like it to a goal of 0.3 to 0.5 milliamps and get a finger twitch, aspirate, and then inject the remaining 15 cc's of 0.25% ropivacaine. For our next block, everything's the same up until the point of timeout. So with the TAP block, what this is for is going to be abdominal post-op analgesia. It's going to allow us to reduce the amount of opioids we give to our patient, just higher patient satisfaction. We can do this under general anesthesia, so the patient might not mind it as much. So what we're looking for as we scan posteriorly is the aponeurosis of the transverse abdominis. We're going to go through the external oblique, internal oblique, and transverse abdominis, and we see peristalsis right here at the bottom of the screen, and then the aponeurosis, and that is our target. Once again, risks of this would be peritoneal puncture and spread to the femoral nerve. This approach, we use our needle and we go superior to inferior, directly down, and then we'll have our assistant inject normal saline into this fascia and then hydrodissect that. Once we know that we're in the correct area, We can have our assistant aspirate and then inject 20 to 40 cc's, depending on the concentration and dilution, of 0.25% ropivacaine. This is only going to cover one side of the abdomen, so I'd repeat it on the other side if we were doing a full abdominoplasty, including both sides. Once I'm done with this procedure, I'm going to document everything and continue to monitor my patient throughout the procedure.